All right, so I'm waiting for the doctors to come back. It's about 20 after 12, wondering where Greta was. And they wanted to wait for her to get here before they talk to me, so there's no communication gaps. I understand that. And Greta's downstairs in the garage right now, so she'll be up shortly, and we'll be back. I'll probably just turn this on and leave it on the table rather than filming anything. So anyway, just want to record. Okay.
Oh yeah, the data. Do you want to grab a chair? Sure. The data's the data. Okay.
Oh, I guess I put this on the side.
Oh yeah. It's hard to remember.
It's all good. Did you start the thing?
Yeah.
Okay, good.
Yeah.
Just making sure.
Yeah.
Okay. Okay, so we got scans and they don't look very good.
Right.
Okay, we kind of knew that. You've been off treatment since November because it wasn't very tolerated. The PET scan shows that
You have a good poker face.
I do.
She doesn't.
Yeah, I've been told that
The mask helps.
you can kind of read everything across my face. My mother's told me I
I'm
can never lie.
sorry. That's
okay,
my defense mechanism again.
That's okay. My mom says I can't lie about anything because people just read it right over there. So PET scan shows progressive disease.
Yeah.
We see the spots in the lungs, bones, kind of the back of the belly, chest wall, and maybe in
Would
the
that
skull.
be right here?
Well, they see some stuff there from the
Because
MRI
that's
too.
where that pain is. I thought I pulled the muscle at work 3 days ago. Anyway, sorry.
Oh no, it's okay. And we see actually stuff in the bones themselves too.
Really?
And then the MRI. So remember, you're having the headaches.
Yes.
They're seeing what they consider leptomeningeal disease. So as opposed to actual spots within the brain itself, like the meat of the brain, they're seeing kind of these punctates, so like little polka dots, kind of over the brain, and then there's this hyperintensity. So we check T1 and T2, and we see what kind of lights up a little bit more, and then it's a little bit brighter. And they're seeing multiple spots kind of over here, over the head. They're seeing it over
Right
the
here?
Yep. They're seeing it over the
this is
occipital
what I'm
lobes,
seeing.
kind of in the back. They're seeing some areas of the lateral ventricle, so the inside of the brain has like these kind of areas that are open when you see it, and some of those are lighting up too. And on the MRI of the brain, MRI of the spine, they're also seeing leptomeningeal carcinomatosis along the entire cord. So when we say leptomeningeal carcinomatosis, you've heard of meningitis.
Mm-hmm.
Okay. Meningitis is an infection of the lining that goes around the brain and around the spine. Okay, you have the actual brain, but it's sort of like this web that goes around it. And that's an infection. Leptomeningeal carcinomatosis is that same lining has little spots like cancer in it. And we see the spots around the brain, we see the spots around the spine itself. We have just got off the phone with Dr. Nastis, and he said, okay, well, when we see that, first we'd want to start steroids. Okay, that'll help decrease any kind of inflammation, which may be causing some of this stuff
pain.
here. Some of the headache that you're having here, as well as some of that back pain you're having there. So that started. He'd like us to call radiation oncology. Now, radiation doesn't work a lot with melanoma unless there's one specific spot that they would focus on. This would be something that we would radiate all of this as well as all this. But he said if there's one spot, particularly since you're having that back pain, then that would be reasonable. However, what he really wants to do is go ahead and start treatment. He wants to start Mektovi, M-E-K-T-O-V-I, and Braftovi, B-R-A-F-T-O-V-I. Both are pills.
Oh, they're oral.
Both pills. Both are pills that you take every day.
Mm-hmm.
Side effect profile is similar to the stuff that you had from before. Remember the stuff you stopped in November. He is going to see what he can do about dose modification, see what he thinks, but given the amount of disease we see on the PET as well as the brain MRI and spine MRI, he wants to get that started.
Mm-hmm.
He is having Heather right now go ahead and send that to pharmacy so we can try to get that insurance coverage, this, that, and the other. So that way he's hoping that you can pick it up in pharmacy. And then he's planning on seeing how you do on the steroids, see what radiation says, and then we could let you go home.
Today?
Maybe we'll see what radiation says. I don't think radiation's going to say that you need radiation because there's no like clear big spot pushing on part of the spine. So they will probably say fine, and then just let you go on steroids, then he wants to see you in clinic next week.
Yeah, West County, hopefully.
Mhm.
Okay.
So that's kind of his plan, and like we came in here earlier before you got here, we thought we'd just sit and chat about all of it, as well as
Mhm.
treatment options, and talk to Dr. Anastas.
If he does this oral, can he still do the immunotherapy that Dr. Beatty had planned on him doing?
I think he wants to switch to this, given the amount of disease right now. So the deal is that immunotherapy tends not to work as quickly as some of our targeted agents. And given the amount of disease and that you're starting to have symptoms, that might be a better way to go. There'd still be a role for adding immunotherapy either later on or instead of. And so he's gonna kind of watch closely how you do and how you respond, how you tolerate it,
Mhm.
what your liver and kidney functions, all the different stuff that we monitor as we're giving targeted agents.
Right. Now, how about transferring care back to Beatty?
So,
Because I
Huh?
live out in O'Fallon,
Uh-huh.
and it's easier to just go to like St. Louis.
so
Dr. Beatty has the same capability,
Yes.
right, to order.
yes. So I would probably start, at least see how you do with this, how you tolerate it, how the first liver, kidney, electrolytes, all that goes, and how the first scan goes. Usually once people are relatively stable and are doing well on tolerating a regimen and responding, it's a lot easier to transfer as opposed to when you initiate a treatment. But that is up to you, whatever you're more
Right.
comfortable with.
I mean, just make a comment here.
Oh, yeah.
Don't take it the wrong way.
Yeah.
I haven't seen him at all. Dr. Asnatis or whatever, and he's communicating by phone, and that kind of bothers me. There's no personal hands-on relationship here. He works down here too, I know, and I haven't seen him once. So that bothers me, and the personal has to be there in order for the patient to respond.
Right.
And that's why I might just transfer back to Beatty.
Well, both of those are reasonable. I know that in an institution like us, we usually take turns taking care of folks in the hospital. Like I'm one of the lung cancer specialists, so like I have my clinic this afternoon, and so then I see my patients, and I know some of my colleagues go to various places. I have folks who go to our Illinois parts, and I go to our St. Peter's part, so it depends on.
I
Yeah.
get
But
it.
it depends on what
I
your
just
comfort level is.
wanted you to let me.
And she's so nice anyway.
Yeah, I know.
But it depends on what your
She
comfort
doesn't
level
have
is.
to talk, and I can read what she's saying.
Right.
I'm just kidding.
Yeah.
Just kidding.
The data is the data.
Yes, it is.
The drugs are FDA approved. That's nothing different from here versus there.
Mhm.
And so a lot of times is that where you have the most therapeutic relationship, whether it's here with Dr. Anastas, whether it's there with Dr. Beatty, that either one is fine.
Yeah.
I usually though, when people have had progressive disease and it is leptomeningeal spread, which is a little bit more rare, and it's a worse prognosis than just regular metastasis to the liver or the lungs. You may need a little bit more closer follow-up as you're getting this initial treatment. Just technically speaking. Other than that, if you're tolerating it well and you're responding, I think that's an easier time to transfer. And that way everything is smooth, nothing gets dropped, and if there's other stuff that we have to engage, either neurosurge or radiation oncology, it's a lot easier to do that in a multidisciplinary. But again, up to you.
Okay. Is there any talk about time frame here as far as life expectancy?
Depends on how you do.
Mhm.
So the deal is that generally leptomeningeal disease is one of the poorer prognosis in terms of metastases. But the deal is that it depends on how well you respond. And kind of proof's in the pudding, right?
Right.
You start treatment, if it starts shrinking, then you are automatically on the longer side. The problem is leptomeningeal disease doesn't happen very often, so trying to get all the data is, particularly when you then subset it by the different cancers, is a lot harder. We know if it's in lymphoma, it tends to be a lot easier, simply because it just responds more easily to chemo. Leptomeningeal seed in breast cancer tends to really respond to methotrexate, which melanoma doesn't. So in my lung cancer people, leptomeningeal disease, usually the prognosis is less than 6 months, even with the best treatments. The deal is that melanoma is very different, particularly with people who, we found out that melanoma is very reactive to immunotherapy. We found out it's very reactive if you have the BRAF V600E mutation to these combo drugs regimens. So, and a lot of that has very good penetration into the CNS. So if you have leptomeningeal from GI or from lung or from colon or from pancreas, it's a lot worse, but it's hard to put a number because there's not many people like you.
But you're saying that it,
Awesome.
it does respond well to immunotherapy, basically. That's what Dr. Beatty had said also.
Right.
Even if it were in the brain, that it responds pretty well to the
Yes.
No.
immunotherapy.
Since I remember lymph node yesterday,
Mhm.
since it's in there, is there something just accelerated now that, as far as the disease, I mean, can it get any bad, any worse?
Well, it's pretty much all over right now.
Yeah.
You know,
Okay.
and the deal is that it's one thing. It's if it's in the parenchyma, the actual meat of their brain, because the crossing the blood-brain barrier, it's actually one of the worst to have leptomeningeal, to have it kind of in the spread outside the brain, around the brain as opposed to inside the brain.
Okay.
One of the other ones is skin metastases. Those two metastases tend to be the worst prognosis of all the metastases. But the deal is that you have a melanoma that you haven't actually had that much treatment yet, right? And you have been off treatment.
Yeah.
And the deal is that this PET and MRI is just your new baseline.
Well, we needed to get it done.
Yeah.
That's for sure.
Yeah, but what it is your new baseline. You've been off treatment since November. You know,
Yeah.
it's now January. Whether or not it has mutated and become more aggressive is difficult to tell because this is just,
Mhm.
you know, you've been off treatment. So the proof really is you start with your baseline, you get your treatment, and then you see how you respond, and you see how much that difference is.
Right.
That tells me a lot more about prognosis than anything you can quote off Google or whatever off the internet,
Right.
Because
But
all those are
Google's
just like-
always right.
Huh?
Google's
Well,
always
you know, there's a
right.
few times when I've like looked at Dr. Google myself for my kids, but the best proof
Yeah.
is like how you personally do it, because some of
Mhm.
those numbers, you know, they are taking the people who are up walking about doing their thing, and the people who are like in the bed can't do anything. And those numbers, all those percentages, don't necessarily. It's hard to extrapolate that to an individual.
So it's not like he's gonna die 2 weeks from now, and he's definitely got hope.
Yeah, the fact that he has such little symptoms based off the amount of disease is actually a really good sign. He doesn't have a lot of constitutional symptoms, you know, night sweats, weight loss. You know, you don't look bad. Your nutrition's actually pretty good. Your numbers all look good. Your
You work
electrolytes
every
and
day.
counts. Yeah, exactly. Because you have that what we call enough performance status or body strength, it gives us a lot to work with, which
Mhm.
allows us to be more aggressive. And the fact that you don't feel much is actually a good thing, because we would sometimes have a very different conversation if you didn't feel so good. Because
Right.
then that really limits my options about what we can do, or rather, sorry, Dr. Nass's options. But that really limits what we end up doing. But the fact that you're relatively healthy, if this is progression disease off treatment as opposed to progressing right through treatment,
Right.
tells us a lot more that
Yeah, and
we
the
should
lung
go.
was shrinking too, so
Exactly.
when I was on the stuff that,
And then sometimes you just have to be more aggressive about your supportive palliative care as you're kind of getting through this, because it becomes a balance of how much side effects we give you through your treatment versus how much side effects, you know, that we get from
Right.
the cancer, right? And then, you know, you balance it
I
out.
mean, I
and
can
that's
handle
also,
nausea and throwing up and,
Uh-huh.
and just feeling weak, but when it attacks my other organs,
Yep.
that's not good,
exactly.
so,
We'll get through this.
Yeah.
Got it.
yep, we'll do our best, at least, that's,
We're gonna put on our marching boots and start fighting it more.
So,
I already got my mental marching boots on,
Good.
so,
so
So I mean, that
body-
makes sense to me, that if this works faster to start getting it under control,
Mhm.
and then maybe moving to the immunotherapy just to keep it going.
we'll see what happens with the first phase,
yeah, and if you respond really well to the dual agent now, then
I will,
you just stay on it, right? Because if you respond well and you tolerate well,
Mm.
you stay on it until you either don't tolerate or you progress, or both.
Mhm.
And that way you still have immunotherapy for your back pocket, because we hope to keep you around for a while.
yeah,
I'm
That's
sure
why I'm
she'd like
here.
to- Yeah, exactly.
I mean.
So the deal is that sometimes you don't want to stop something if it's working and
Yeah,
tolerating
don't
it.
fix it if it's not broke, right?
Get as much benefit as you can, because then sometimes what we do is we do sequential therapies, whether it's immunotherapy, targeted agents, or chemo. We do it sequentially, and you get the max out of each course you can before you move on to something else.
Right.
Well, because sometimes I have patients who are like, oh, I heard of this new thing, I want to go switch. So like, well,
Right.
you know,
Yeah.
I have to think about the now, and I want to think about the later, and
Mhm.
I kind of think about everything along the way.
What is your name again? I'm sorry.
Oh, that's Bagstrom. Sorry. My nurse tells me this all the time. For
You're
like
so
the last
nice.
10
I
years, I
appreciate
just start talking and I forget to introduce myself. That's me. Sometimes it's easier to see in black and
Is
white.
it-
Yes.
And I'm probably on your discharge summary somewhere.
You
So.
are.
Associate professor. Ooh.
Yeah. It's
You're
just,
the big wig.
actually, they're working on my promotion to professor, but that's it's more paper.
We'll see how this case goes.
Well, you never know. I better some knock on some wood here,
Let's
right?
see. When are the interviews?
Oh, it's more paperwork and stuff. The other things I've done. You know,
Oh,
it's just like anything else. You take it one thing at a time.
Yeah.
You try something, see how it goes. If it works well, great. If it doesn't, you pivot. Right? It's true of cancer. It's true of life, and you just kind of go from there.
right.
Now, is this something that maybe he should, he works a lot. Should he maybe just stick to a 40-week and not be working 50, 60 hours a week?
Whatever he feels like.
Okay.
Because we actually find that if you're working, it keeps up your performance status, right? If you feel not so good, then cut back, you know. Don't do the 1 step forward, 2 steps back. I know, I see you pointing. Yeah. Hey!
The extra 20 your cost for her.
Sometimes it's a good thing because it keeps their mind off stuff and,
Right.
people are up and going. Sometimes people want more time with you.
Mm-hmm.
Yes, exactly. And so that's okay too.
Sometimes maybe.
So-
Yeah.
I got you back.
Yeah, so sometimes they don't want you at home and they're saying,
You know, I thought my
Don't work.
I thought my seat
Or
I thought
sometimes
my
they have this
CPAP
honey-do
had
list.
stopped working one night, but I woke up, the pillow was on my face.
Oh, well, I'm not sure I want to go there. But she might have a really long honey-do list for you at home. I know I do for my
You know
husband.
what?
Yeah, yeah.
Yeah.
It's never ending.
No, well, it's all good.
It's never ending, but that keeps my mind off
Exactly.
of everything.
Well, it's good to know that we're not in a hopeless situation.
Oh no, there's more stuff. If you had a worse performance status or your organ function wasn't so good, your counts were so good, we would have a different discussion. But that's why it's always easier to kind of have this discussion when we're all kind of sitting here. That way
Yeah.
we can kind of talk about scans, talk about treatment. You have Dr. Anas's, expertise, and then we kind of talk through all this.
This is kind of probably an off the wall
You can ask
question, but
whatever you like.
I'm wondering if these medicines that he's going to put him on, will they help with the pain also, or will he need to have a separate pain medication or something?
Well, he might need some pain medication, but usually as we treat, if the cancer is the underlying reason for the pain, then treating the cancer will help. But in the meantime, it doesn't, you can still have pain meds, because we want you to still be up and functional and,
What about this blurry eye? Does
That I-
that have anything, or should I go to my eye doctor?
we can have them take a look. Sometimes that might be the leptomeningeal stuff, particularly since it's in the occipital lobes. The occipital lobes are kind of the back of the brain. So, you have your eyeball, you have your optic nerve, and it goes to the occipital lobe. That's where the actual the images are interpreted by the brain. So some of that is actually have some enhancement on your MRI.
Okay.
So I would
And
start
then
treatment and kind of
This
see.
little bump here,
Mhm.
what is that?
On the thing material on the PET, it looks like you might actually have some the actual bone itself.
Bone?
Yes,
That's a bone?
yes, you
So
have
I
bone,
just push it back down.
or you have skull.
Yeah.
Is that something he should have his dermatologist remove, or?
I wouldn't right now, because if his counts start having issues, you don't want any kind of bleeding or infection,
Okay.
unless it's really bothering you.
No, it doesn't bother me.
Yeah.
It just, it popped up and I thought, man, that feels just like the one that started this whole mess.
Yeah,
So,
yeah, the one that he went for a year and a half and got just diagnosed by his
Yeah,
primary
skin
care
tag.
doctor.
And if
Even
it's
though we got the
melanoma,
size of my thumb, they kept saying, oh, it's okay, it's just a skin tag.
and if it's
Anyway,
melanoma,
that's-
it will still be treated
sorry,
by the dual
it's
agent
angry.
therapy too, so.
okay.
Basically, I mean, it'll be systemic, it'll treat you from head to toe.
All right. Great.
Do most people tolerate this fairly well?
Yes.
Awesome.
And if not,
And he's
we give
pretty tough.
additional nausea meds, or if we need to do anything else, or if you have reflux issues, then we give like a proton pump inhibitor, like a omeprazole or something else for stomach.
Okay.
Whether or not we give you other stuff for reflux, if we give you
We
any
started
additional
with the
pain meds,
steroids.
nausea meds, yeah,
Okay.
all those different things.
Well, it sounds, we have a plan.
Yeah. If I get out of here today, I can go to work tomorrow.
Or just have radiation CU, steroids, you already loaded them with 10, and we'll continue the 4Q6 of dexamethasone, the high dose steroid.
Mhm.
And then Dr. Anastas is having Heather, he already signed the chemo orders, he's having Heather submit that for insurance. And so while we're chatting, all this, sorry, there's lots of stuff that sometimes happens in the
Right.
background, so
Yeah.
that way we can get insurance coverage if we have to do any kind of prior authorizations or any additional paperwork, and then, yeah.
Okay.
Go from
Well,
there.
that'd be something I would need to know if it's covered. If I'm in the net, I'm pretty sure he's in my network.
Yeah.
I think I checked
You
that,
checked that,
called, and they
called,
said
yeah.
yes.
Yeah.
So that should be in my network too. If something's not in my network, I need to know about it right away. 'Cause-
Yeah. Well, sometimes it kind of depends on some of the targeted agents, what coverage they
Mhm.
have, and if you have to do additional formulary or do peer-to-peers. I think I spent like half my life like doing peer-to-peers and prior authorizations for my patients, and
Uh-huh.
I spend more time talking to insurance companies than I do with my patients, just to get them the care that they need. And it's something that they
Get
don't
things
see, because
covered.
that's again in the background, but
And we went through the Walgreens over
Yeah.
here. It wasn't the Walgreens store, it's the
Walgreens
Walgreens
specialty.
pharmacy. And all that was covered, so,
Yeah.
I mean, if we
So-
had to go through them, we'd go through them too.
so they're working on that right now, so.
Alright,
So it would be kind of probably the same thing where the first, oh, it's gonna be $8,000 a month for this medication, and then
yeah, can't
Dr.
do that.
Beatty was able to get it covered.
Yep.
Right, so,
Yeah, then we usually have a pharmaceutical company that makes it. Usually there's a paperwork that we have to fill out, we sign it, you sign it, and then we send it off.
okay, all right.
Alrighty,
Well, I appreciate your time and appreciate your positive.
Oh, yeah, totally. Yeah. Well, yeah, that's why we're like, he was like, oh, I want to hear it. I was like, well, let's wait. We're just going to sit and chat
I was hoping she was on her way in the afternoon.
I was home praying.
Yeah,
so-
well, you're here, so.
Yep.
All right, well, we go from here and move forward. And
Appreciate it.
we'll-
Do you have any idea what time radiation will be in? Because he really wants to come home and I want him home.
Yeah, well, we've called the consultation. I don't think, if you're feeling fine and it may be a while, we could just do an outpatient radiation oncology consult. That may take a little bit longer to get in to see them, but if that's something that you really want to go, because you don't really need a lot of inpatient criteria, you don't really need to be here in the hospital. We try to minimize any kind of other issues.
Right.
Yeah, if they're not going to be coming here soonish, we'll let you know, and then we can just let you go.
Okay,
Wonderful.
I'll get your appointment outpatient.
I'll agree to that. I got dressed to leave. I'm ready to leave, so.
Well, I think you were ready to leave when you got here. You were
Yeah,
kind
I
of like,
was.
hi, can
Yeah.
I say, I was like, no.
But I knew we had to have these scans, so
Yeah,
it wasn't gonna get done as fast if we didn't come in here, so.
and that was Dr. Anastas' thing,
Yeah.
so I
Right.
appreciate that too.
Exactly. He kind of really pushed to try to get all this stuff, and he made a whole bunch of different phone calls to make sure,
Okay.
because
We
sometimes
do
we're like
appreciate that.
waiting to get, oh yeah. Yeah, he just wanted to make sure that you were taken care of.
Well.
I don't want to get stuck in the garage again tonight though. I couldn't get out last night.
Oh.
I put
I
my
made a
ticket-
few phone calls.
Oh. He's like, well, get out of here before dark, and I tried to, and I put my little ticket in, and it started spitting other tickets out at me. So I didn't know which one was my ticket.
Oh
And so I put it back in, I tried to do the credit card, and it wouldn't, so I had to back up. Thank God nobody was behind me. And I caught some guy going to his car. I'm like, do you know how to get out of here? And he's like,
If
well,
there's a little button, a phone
Yeah.
button. I had issues last week. You just call them. I'll show it.
yeah, she finally told me, just tear up your ticket and have a good day. I was like,
Oh,
thank you.
jeez. Jeez.
All right. Any more questions?
No.
I don't have any more.
Okay.
Not that I know of right now. As soon as you walk out, you know how it goes.
If you think of stuff, let us know.
Yeah.
We're around. And then, we always recommend, we have the Simon Counseling Center. We're doing mostly conference calls and
It's
stuff
for
like
you.
that. Well, it's for both our patients as well as our families. We don't even bill your insurance. It's all free.
Okay.
We usually recommend that with new diagnoses as well as when people have progressive disease. because we want to keep you not only strong physically, but also mentally, because, you know,
Yeah.
it's a long journey. I mean, you've been doing this for a while now. So that's some of the things to help support you as you kind of go through this.
Thank you.
Okay?
Alrighty.
So just a thought.
That day will come, I'm sure, but right now I feel
Some
pretty strong.
people like it, some people don't, and it's one of those things we want to make sure we offer. Just like we offer social work support, or we offer case management or nutrition support, or it's just one more thing about taking care of a cancer patient.
Well, I think I've done a lot in life, and I got a couple more things I need to get done. So if it doesn't happen, it doesn't happen. But
Well, and you
I'll
promised me that I
make
could
sure to
die
try to
first.
stick around to do it.
You promised you what?
You promised me that I could die first, anyway. so-
Okay.
Well, yeah,
And
but
he's
we
good
have
at
this
keeping his
argument all the
promises.
time. You know, I only tell you that to make you feel good.
Isn't that what you're supposed to do?
Yes.
Right, yeah. I've been married for, in June.
I know, 25 years.
Yeah, exactly. So I'm kind of hoping that, you know, here keep like making
Yeah.
me feel good for another 25 years.
Yes, yes.
You just got to go from that, right?
Right.
Mm-hmm.
And sometimes you have to just promise, and my husband just says, yes, dear. But he's like,
He does that
I
a
do
lot.
that a lot.
yeah,
He's really good, yeah.
okay, well,
I
good.
know my place.
He likes to tease, but he knows how those bruises.
But I'm a
happen.
strong-
Oh,
I'm
yeah,
a-
we were talking about the bruises yesterday. That's right.
I'm a strong man and have taken care of my family, and
Yes,
that's
you
all I work for. So they're happy, I'm happy.
Sounds good.
And sometimes, yeah, I'll break down, but
You're allowed.
I'm allowed. That's right. So we're good.
Okay, well, if you think of other stuff, you know, literally as we're
We'll
walking
write
down
it
the
down.
hallway, yeah, just or find us and we're gonna go from there.
Okay.
I have to run
Appreciate
over
both
to
you guys.
I have to run over to clinic, but if there's something that you want me to come back, it might be a little bit later on this afternoon, but
Yeah.
so,
We just
I
wanna
don't
get
think
him out
it'll
of
be.
here.
Yeah,
okay.
that's all I really worry
Get
about
you
is
home and
getting
straighten you out, mister.
Yeah.
out. That way I can take all the pain medicine I want.
Oh, yeah.
Okay, and on that note,
Poker face. She's just a call psych.
well, it actually wasn't psych I was gonna call, but that's okay.
Okay.
She heard you, so it's all good.
Yeah.
Okay.
No,
Well-
we're good.
If you think of other stuff, let us know if other questions or concerns come up,
Alrighty.
okay?
Thank you very much.
Appreciate it.
Okay.
Thank you.
You're welcome.
I would shake your hands, but you know,
Yeah.
Yeah, it's just one of those things, right?
crazy COVID stuff.
Yeah.
Take care.
You
Have a
too.
great
Thank you very
day.
much. Let me smell some pepper. Take my mask off so I can have a drink.
Oh my God, yeah. Keep forgetting. Well, that's that. See ya.